Good day, and welcome to Beating Cancer, a transatlantic conversation about cancer policy. An event brought to you today by the European Union in partnership with the National Coalition for Cancer Survivorship and the University of North Carolina, Chapel Hill's Center for European Studies. I'm Noam Levy, a senior correspondent for Kaiser Health News, which, for those of you unfamiliar with us, is a nonprofit news organization based in Washington, D.C., covers health policy around the United States. It is not, I should say, affiliated with Kaiser Permanente. It is my honor to be here today moderating what I am sure will be an informative and stimulating conversation about the European Union's new Beating Cancer plan. We'll hear today from several European leaders and U.S. officials about this important new document, and then hear some reflections from some experts on both sides of the Atlantic. Before we begin today's discussion, a couple of quick housekeeping notes. We're going to start today with, as I said, a few presentations, including one from Ms. Stella Kyriakidis, the Commissioner for Health and Food Safety for the European Union, who will present the new EU plan. After these presentations, I will moderate a panel discussion with our group of distinguished experts. We'll then take some questions from members of the audience who are invited to send in questions electronically or raise your hand virtually so we can call on you to ask questions live. To that end, at the bottom of your screen is a menu bar where you can submit questions through the Q&A function. Or if you'd like to ask a question using your webcam, please use the raise hand function. Feel free to submit questions at any time, and we'll get to as many as we can during the Q&A portion. One last note, we are recording the presentation today, and it will be available on the EU in the US YouTube channel. I'd like now to introduce Commissioner Kyriakidis. Over the last year, the Commissioner has been leading the Commission's work to coordinate the European Union's response to the COVID-19 pandemic. Her work has also included launching Europe's Beating Cancer plan to improve cancer prevention and care, developing a new pharmaceutical strategy to ensure that Europe has affordable medicines to meet its demands, and leading the ambitious EU for Health program. Previously, Commissioner Kyriakidis worked as a clinical psychologist in the mental health services of the Ministry of Health of the Republic of Cyprus in the area of child and adolescent psychiatry. She also founded the first breast cancer advocacy organization in Cyprus, Europa Donna Cyprus, where she served as president from 2000 to 2015. And she was president of the European Breast Cancer Coalition, Europa Donna. Commissioner, the floor is yours.
Thank you very much. Thank you. And it's a great pleasure to be here with you today, ladies and gentlemen, to share with you Europe's Beating Cancer plan, a plan that has been a priority from the beginning of the mandate of this commission, a plan that is one of the priorities of President von der Leyen, and that we were able to This past year has, of course, been challenging at many levels. And the COVID-19 pandemic has reminded us all of the foundational role that health plays in our economies and in our communities. The pandemic has also very clearly highlighted that the greatest challenges facing us are the shared challenges, and we must tackle them together. It has underlined the importance of solidarity, of multilateralism, and of global cooperation. So I'm delighted to be able to join you here today and to present a new major pillar of EU's health policy, Europe's Beating Cancer plan. In 2020, 2.7 million people in the European Union were diagnosed with cancer, and another 1.3 million lost their lives to cancer. Today, European Union accounts for 1/10 of the world's population, but 1/4 of the world's cancer cases. Unless we take decisive, coordinated action, lives lost to cancer in the European Union are said to increase by more than 24% by 2035, making it the leading cause of death. The EU urgently needed a renewed commitment to cancer prevention, treatment, and care, one that recognizes the growing challenges and maximizes the opportunities to overcome them. Europe's Beating Cancer plan is our collective response to this need. It reflects a political commitment to leave no stone unturned in our fight against cancer. The plan will address cancer in a holistic way through 4 pillars: prevention, early detection, diagnosis and treatment, and quality of life of cancer patients and survivors. Research, innovation, and digital technologies are the starting points for this new approach, an approach that places the reduction of inequalities at the center of the cancer plan. The first pillar aims to prevent the preventable. It will address key risk factors like smoking, harmful alcohol consumption, obesity, and lack of physical activity, and environmental pollution. We aim to eliminate cancers caused by the human papillomaviruses and to vaccinate at least 90% of the EU target population of girls and significantly increase the vaccination of boys by 2030. The plan's focus on prevention will also benefit other non-communicable diseases, such as obesity, cardiovascular disease, and diabetes. The second pillar looks at the early detection of cancer, which we all know saves lives. Digital tools play an important part of this effort. We will develop a new EU cancer screening scheme to ensure that by 2025, at least 90% of the target population is offered breast, cervical, and colorectal cancer screening. The third pillar is that of treatment. We want to ensure better integrated and more comprehensive cancer care, and we will be addressing the current unequal access to quality care and medicines. The cancer plan aims not only to ensure that cancer patients survive their disease, but that they live long and fulfilling lives, free from any type of discrimination and unfair obstacles. With this goal in mind, the fourth pillar looks at survivorship issues, such as rehabilitation, the emotional distress, potential tumor recurrence, metastatic disease, and fair access to financial services. This plan aims to be a game changer that will help member states turn the tide against cancer. The new EU for Health programme and other financial instruments will provide an unprecedented support of almost €4 billion to EU member states and stakeholders to help them build more robust health systems and reduce the suffering caused by cancer. Good health is an investment, and it is one that will pay off 1,000 times over. Ladies and gentlemen, effective health policy depends on effective collaboration and not just at times of crisis. Multilateralism and global coordination will continue to guide the European Union's health efforts, and we are determined to work closely with other countries and our international partners such as WHO. We want to share good practices, expertise, and lessons learned, but we're also eager to listen and learn from other countries, such as the United States. I want to take the opportunity to congratulate you on the 50th anniversary of the National Cancer Act. The adoption of the National Cancer Act in 1971 changed your approach to cancer prevention and care. It cemented your commitment to science, establishing networks of cancer centers, clinical trials, data collection systems, and advanced research. The European Union has been working to tackle cancer for decades, and its actions, for example, on tobacco control, have saved and prolonged lives. Now, with Europe's Beating Cancer Plan, we mark the first steps of a new era of cancer prevention and cancer care. This, as I often say, is the beginning of a journey. It is a moving, breathing plan, and its success depends on collaboration and genuine partnerships. We work together with all stakeholders and patient organizations in order to move forward with this ambitious plan. We work together with the European Parliament, and to put this plan together, I would like to just share with you that we were over 13 commissioners that contributed to it, and we will continue to work like this. The collaboration between the US and the EU, between American and European industry, is going to be a very important part of this effort. And your insights and experiences and perspectives are crucial. And we look forward to hearing them. So let me finish by thanking you for your attention, by asking you to join us on this journey, and by saying that our commitment is there and we have an opportunity now in the EU to change the realities of this disease through EU's Beating Cancer Plan. And we cannot afford to fail our citizens. Thank you.
Thank you very much, Commissioner. We now have a message from U.S. Congressman Derek Kilmer, representing Washington State's 6th Congressional District. Congressman Kilmer, who was elected to Congress in 2012, is co-chair of the House Cancer Caucus and has over a decade of experience working in economic development in the Puget Sound region of Washington State. Before being elected to Congress, Mr. Kilmer served in the Washington State Legislature. Congressman?
Hey folks, Derek Kilmer here, U.S. Representative for Washington's 6th Congressional District and one of the co-chairs of the Congressional Cancer Caucus. I want to start by thanking our European partners for putting this conversation together and for the opportunity to discuss the Congressional Cancer Caucus's work in the 117th Congress to advance the fight against cancer. As someone who's been impacted by cancer in my own family, I take my role as co-chair of the Congressional Cancer Caucus seriously. I'm committed to supporting the patients and families who continue to face the burden that a cancer diagnosis brings, while also working to ensure that the American federal government steps up in this fight to defeat cancer. Without a doubt, the COVID-19 pandemic has significantly impacted the cancer research community and the broader scientific workforce in America. Besides having to close labs and implement social distancing protocols when this pandemic started, U.S. researchers from nearly every discipline have worked together and pivoted to focus on COVID-19 related research to fill the gaps in our existing knowledge on the coronavirus. While this research was instrumental in expanding our understanding of the virus, it has undoubtedly had broad ramifications for other scientific efforts, and early reports suggest that cancer research was no exception. However, the Congressional Cancer Caucus is aiming to ensure America refocuses its efforts on defeating cancer with three main goals in mind for this year. 1, investing in research. 2, examining long-term effects on cancer care from the pandemic. And 3, addressing racial disparities in cancer treatment and outcomes. With cancer as the second leading cause of death in the United States, we know that there is a hunger to defeat these deadly diseases. But we also know that in recent years, the federal investment in research has not been up to par. For example, prior to the pandemic, the success rate for grant applicants at the National Cancer Institute had dropped in recent years by 2.4%, indicating the thirst for funding in the cancer research community and the relative underfunding that has been provided. So what can Congress do to address that need? Well, as a member of the House Appropriations Committee, I'm working to ensure that the federal government increases its investment in the National Cancer Institute and continues to support both the research and the researchers driving new innovations and discoveries in cancer. Last year, I worked with members of both parties to advocate for almost $7 billion for the NCI in the Consolidated Appropriations Act and the 21st Century Cures Act. This represented an almost $119 million increase over the previous year's appropriations. That funding is intended to advance new diagnostics to catch cancer earlier and new therapies to eradicate the disease. We also know that with a new president comes new opportunity. And I was thrilled to see President Joe Biden say in February that once the coronavirus pandemic has been defeated, his words were, "We're going to do everything we can to end cancer as we know it." To that end, the president has already proposed a plan which would allocate $250 billion to the U.S. research enterprise over the next several years. This substantial investment would help rebuild U.S. infrastructure, create new jobs, and spur new innovation, including in the cancer research sector. I'm committed to working with my congressional colleagues to advance these proposals to support our scientists and ensure that they have the resources they need to find new cures and save lives. Second, we've got to take a look at how this pandemic has affected the fight against cancer. Already we know that fear of the COVID-19 pandemic has led to a substantial delay in screenings and delivery of treatment within the cancer community. For nearly the entire last year, those stay-at-home orders were critical in reducing coronavirus transmission. Hospitals and healthcare professionals have been forced to temporarily discontinue screenings, to shift to telehealth monitoring, to delay non-immediate surgeries and procedures. It remains unclear what effect this will have on cancer mortality in the coming years, and Congress and the U.S. federal government need to take a deep look at this in partnership with our friends across the pond. And finally, we know that across the United States, underserved populations and communities of color have been disproportionately impacted by both the public health and economic effects of the pandemic. Unfortunately, similar trends are observed in cancer outcomes as Black women and men still experience higher rates of death compared to white women and men. It's long past time for Congress to tackle the underlying causes of such health disparities, and the Cancer Caucus will be working with our community partners to advance equity in cancer care and mitigate the downstream effects of the pandemic on cancer patients. As such, Congress and the caucus are exploring innovative policy solutions to modernize the cancer care infrastructure to ensure that treatments can be delivered even in the midst of a public health emergency. This will necessitate expanding access to affordable, high-quality health care, modernizing telemedicine technologies, and supporting infrastructure, and reducing financial and societal barriers to care. As we have seen with the pandemic, outreach and engagement with marginalized communities will also be critical to rebuild trust in the healthcare system, to increase rates of early screenings, and to engage diverse communities in the research enterprise. The COVID-19 pandemic has demonstrated that long-term investments in research and support of scientists is essential to mitigating the loss of life, to protecting our communities, and to building a resilient economy. As we look to the future, I'm hopeful that Congress and the federal government under President Biden's leadership can work to vigorously and robustly support the effort to defeat cancer, and we look to do that with our friends across the Atlantic. I want to thank you for this opportunity to discuss our work in Congress. Again, we look forward to working with you and providing new hope for millions of patients and families all around the world. Thanks so much.
Thank you. We turn now the floor to John Ryan to discuss in greater detail the EU's new plan. Mr. Ryan has been director of the European Commission's Public Health Directorate since September of 2016. He's currently the Commission representative on the board of the European Center for Disease Prevention and Control and has responsibility for dealing with tobacco control issues. Current priorities include the development of the EU Cancer Plan, antimicrobial resistance, vaccination policies, and the negotiation of financial instruments to support health, including research. John, the floor is yours.
I would like to, first of all, say that we have 27 member states in the European Union. And I think one of the key messages I would like to give is that developing an EU beating cancer plan is intended to try and ensure that Europe benefits as a whole from a joined up and coherent and unified approach to what is a huge challenge to our health systems now and even more in the future. So one of the key ambitions of the Europe Beating Cancer Plan is really to make sure that Europe is well equipped to deal with this challenge of cancer. And secondly, to try and reduce the level of inequalities, both within our 27 member states and also between the 27 member states. You probably know that if you're traveling in Europe, it's actually excluding the current COVID period, it's actually quite an easy place to travel around in. You can work in other member states, you can live in other member states. But the problem is that the differences between health status of our citizens can be quite huge. And this is one of the top line initiatives, I would say, or ambitions of this plan is to reduce these inequalities between the member states. Now, I thought it would be interesting for you to actually dig down a little bit into some of the concrete actions, and I'll do this very quickly, just to give you a flavor for the types of actions that we will be proposing and launching over the period of the plan. The first is an initiative which we call the Knowledge Centre on Cancer, which will already be launched this year, and will coordinate the scientific and technical cancer related initiatives at EU level. It will act as a knowledge broker and diffusing best practice implementation and issuing guidelines to feed the design and the rollout of new actions under the cancer plan. So in other words, it's a bringing together of the different information tools which we have in order to better guide the actions into those areas where the need is greatest. And the second example which I would give you is the European Cancer Imaging Initiative, which will be launched next year, and which is intended to make anonymized images available to a wide range of stakeholders, including our hospital systems, research and innovators. It will follow the proposal to establish an EU health data space. So in other words, trying to introduce the concepts of e-health and digital technologies into cancer imaging. Some more innovations in relation to data and sharing of data will be the secure access and sharing of patient data through a European-wide health data space. And of course, then a lot of research actions, which we can go into in more detail, which underpin all of the developments which we're hoping to launch at the European Union level. So there's a separate but very closely connected research agenda which underpins this activity. One of the traditional areas where the European Union has been quite strong is in the area of prevention. And I'd like to mention here, as Commissioner Kyriakides did, the rather ambitious effort and a target which we have of increasing vaccination against HPV infection in boys and girls, and thereby setting ourselves the ambition to eliminate cervical cancer and also to reduce HPV-related cancer in boys. I mentioned prevention, but prevention goes wider than vaccination. And we have what we call the European Code Against Cancer, which contains 12 messages to the public on how they can identify and reduce their cancer risk. For example, in relation to skin cancer, I think it's a good example perhaps to give you of the need that the public is aware that having a tan is not necessarily the best way to avoid skin cancer. And therefore, these are messages which you have to repeat, and they need to be scientifically based, and you need to present them in a way which can convince people to change behavior. Commissioner mentioned tobacco-free Europe, and we have an ambition as well to generate a tobacco-free generation in Europe. This will be over the period of 5 years, from 2021 to 2025. So mobilizing a whole series of policy levers in order to try and reduce the attractiveness of tobacco and the availability of tobacco in society. Also, some initiatives relating to alcohol, harmful alcohol consumption, and again trying to lever our different policy tools like labeling, taxation, marketing, all in the direction of trying to reduce the burden of risk. And finally, a focus on healthy lifestyles and physical activity, also benefiting from best practice across Europe and trying to generalize this fight against obesity, which, as we know, has a big impact on cancer. Before I leave the prevention chapter, I'd like to mention as well the alignment of our air quality standards with the WHO guidelines. And this is important in relation to respiratory diseases in general, but also in relation to cancer. And the same applies as regards our climate change, zero pollution activities. These will clearly also have an impact on cancer risk. We should also mention the health and safety at work area, where we have very strong legislation in Europe. And the idea is to reinforce this protection of workers against carcinogenic substances in the workplace. And so these are some concrete examples of what we intend to do in terms of prevention. If I speak now about early detection, we have in place a legal text applying cancer screening in 3 cancer sites: breast cancer, cervical cancer, colorectal cancer. And the intention is to review these scientific guidelines in order to make sure that they're up to date, and also to consider whether we need to extend population screening to other cancer sites besides these 3 cancer sites. But we want to also try and dig down and make sure that the delivery of the cancer screening is done in a quality way, so imposing and introducing better training for screening personnel, but also setting standards through accreditation schemes. Talking now about the chapter of the plan on diagnosis and treatment, the idea is to have best practice centres, cancer centres available in each of our 27 member states. Now, some member states have very well-known cancer centres of excellence. If we think of Germany and Heidelberg, I don't have to give you any more details, but Heidelberg in Germany is really a place where many German cancer experts are focused. But there are many of our 27 member states who don't have these centres of excellence, and we want to try and encourage these national hubs where expertise can be brought together and also exchanged. The ambition is to also increase the capacity of member states to diagnose and treat cancer patients as quickly as possible and to the best standards possible. And this is also one of our initiatives on cancer diagnostics and treatment. And also trying to focus on those patients who are at higher risk because of genetics or because of behavior or whatever, that we actually try and pick these patients out and offer them a fast-track diagnosis and a fast-track treatment. I should mention as well, since it's of concern to the United States, the issue of radionuclear medicine, particularly the supply chain for radioisotopes, which is a problem in Europe. And this is also one of the areas we'll be looking at as part of our cancer plan to try and improve the security of supply of radioisotopes, and also to improve the training and delivery of training to radiologists across Europe. Now, an important and innovative part of the plan is in relation to quality of life for patients, for survivors and carers. And therefore, we're proposing to create tools for patients in order that they can better inform themselves and follow their pathway, their patient pathway, in a more interactive way than exists at the moment. Because we want to avoid that the only source of information is during a visit to the hospital or during a visit to a specialist, but through the use of digital tools, particularly a cancer survivor smart card, we would be able to encourage patients to have a regular flow of information on their condition and to be able to ask questions and get information on their condition. So another concrete example of where we hope to be able to help patients and survivors is in the field of finance, because, as you know, people who have survived a cancer have this diagnosis hanging over them for the rest of their life. And this can have financial consequences if you're seeking to buy a house or take a loan. And therefore, we want to try and improve the access of cancer survivors to financial services, and also the work-life balance and employment rights of patients and their carers, because for every patient, you very often have at least one member of the family or somebody else who is taking care and helping to take care of that patient. So we're very anxious that we should try and mobilize our support for employment rights, social rights for patients and also for their carers. I would mention as well the topic of inequalities, which I began with, because one of the underlying ideas in this cancer plan is to try and improve the level and quality of care and prevention for cancer in Europe by avoiding and reducing inequalities as far as we can. And one of the ideas we have here is the creation of a registry of inequalities. So we really want to be able to measure the inequalities in cancer prevention, early detection, treatment, and aftercare, and then to funnel our financial resources to support initiatives that would be taken focusing on those areas of inequality. So not making the people at the top of the pyramid even better. I mean, I have nothing against that, but the idea is that we reduce the distance between the top and the bottom of the pyramid. And this can be done through a whole series of different things, but I think it's really important that we engage with our stakeholder community as well, so that we have a reality check on this inequalities, and we have the feedback from stakeholders on the ground on what their experience has been. And finally, I would mention the governance aspect. We have a triangle of governance. In other words, we're looking to involve our own member states, 27 of them, in a process where they accompany us in implementing this plan. But also we want to involve the other Commission policy areas and departments. I mentioned research, I mentioned the legislation on health and safety at work, I mentioned the radionuclear people, but there are 45 different areas of policy concerned by this cancer plan. So we really have to make sure that it's a health in all policies, all of government approach. And finally, we're setting up a stakeholder platform where all of our stakeholders will be able to discuss with us the implementation of this plan. And my last word would be on financial instruments. The Commissioner mentioned the budget which has been set aside for this plan, but we really intend to use legislation, budgets, and also other initiatives, not only depending on finance, in order to make sure that this works. So I hope that's given you a flavour for the cancer plan and for the level of detail which we have put on paper, and I'd be very happy to share some information slides with you later on. Thank you.
Thank you very much, Mr. Ryan, for that comprehensive discussion. Finally, I want to turn to Dr. Karen Hacker to give a U.S. perspective here. Dr. Hacker is the director of the National Center for Chronic Disease Prevention and Health Promotion at the U.S. Centers for Disease Control and Prevention, a position she's held since August of 2019. For those of you who don't know, the NCCDPHP has an annual budget of about $1.2 billion and a staff of more than 1,000 people dedicated to preventing chronic diseases and promoting health across the lifespan. Among other things, the center focuses on policies to support health and healthy behaviors, to strengthen delivery of preventive services, and to improve self-management of chronic conditions. Dr. Hacker, welcome, and thank you for being here.
Thank you so much for having me, and it's great to be part of the EU Beating Cancer Plan virtual event today. I have to say, it seems like the only way I'm going to get to Europe in the near future. And anyway, I'm going to start by doing a little bit of information on the cancer burden that we see here in the United States. So the last year that we have incidence data for, which is 2017, in the US there was 1,701,000,000 cases of cancer that were reported. Excuse me, that should be 1,701,315 new cases. And in 2019, there were about 599 cancer deaths, of which 283,000 were among females and 315,000 were among males. Cancer is currently the second leading cause of death in the United States. It's exceeded only by heart disease. So 1 of every 4 deaths in the US is due to cancer. In 2018, total healthcare expenditures associated with cancer were estimated at more than $112 billion. There's the billion. And in the United States, the overall cancer death, so this is good news, has been declining since the early 1990s. And while death rates for individual cancer types have also declined, rates for a few cancers have not changed or even increased. And there's a lot of work that we believe still remains to be done. So as the overall cancer death rate has declined, the number of cancer survivors has increased. And although rates of smoking, which is a major cause of cancer, have declined, the rates of other risk factors, such as, and you heard this already, obesity, have increased in the United States. And we are very concerned about the impact of COVID on things like obesity. Furthermore, the US population is aging, and cancer rates increase with age, as I'm sure you all know. And while cancer impacts people of all ages, we see that certain races, ethnicities, and sexes are disproportionately impacted. And due to social, environmental, and economic advantages, certain groups bear that disproportionate burden of cancer compared with other groups. So some key cancer incidence and mortality disparities in the United States include Blacks and African Americans have higher death rates than all other racial ethnic groups for many, and although not all cancers. And despite having similar rates of breast cancer, Black and African American women are more likely than white women to actually die of the disease. The incident rates of colorectal, lung, and cervical cancer are much higher in rural Appalachia, for example, than in urban areas in the region. So currently, we do not have a national cancer plan in the United States. Many federal agencies have very unique roles that complement each other. HHS is the US government's principal agency for protecting the health of all Americans, and the lead agency is in the US cancer system. It provides essential human services, especially for those who are least able to help themselves. HHS accomplishes its mission through programs and initiatives that cover a wide spectrum of activities, serving and protecting Americans at every stage of life, from conception on up. So some key agency roles, just to give you some understanding. Centers for Disease Control, my agency, is a leader in efforts to prevent and find cancers early and to improve the health of cancer survivors. Our framework to reduce cancer deaths includes eliminating preventable cancers, ensuring that all people get the right screening at the right time, and helping cancer survivors live longer, healthier lives. CDC works with other federal agencies to collect data on notifiable cancer cases in the United States and with national organizations and state and local health agencies to help Americans lower their cancer risk by promoting the use of effective cancer prevention strategies and screening tests. NIH, the National Cancer Institute, you've heard a little about already, is the principal agency for research and development on cancer biology and training cancer researchers. CMS manages federally funded health insurance programs. They pay for the majority of cancer costs and set reimbursement policy. The FDA ensures the safety, efficacy, and security of cancer drugs, biological products, and devices for cancer diagnostics and treatment. FDA also has responsibility for regulating the manufacturing, marketing, and distribution of tobacco products. So although there is no national cancer plan specifically, the Healthy People Initiative provides national goals and is designed to guide national health promotion and disease prevention efforts to improve the health of the nation. Released by HHS every decade since 1980, Healthy People identifies science-based objectives which target or to monitor progress and motivate and focus action. The Healthy People 2030 is the fifth iteration of the initiative and continues in this tradition with about 350 core objectives that are tracked over the decade. And the Healthy People 2030 objectives are based on recommendations of the HHS Secretary's Advisory Committee for 2030 and the collaborative work of many of the agencies I've always mentioned. The cancer objectives in Healthy People 2030 promote evidence-based cancer screening and prevention strategies to improve care and survivorship for people with cancer. There are 16 cancer objectives. A recent 2019 report from the National Academies of Sciences, Engineering, and Medicine, sponsored by the American Cancer Society and the Centers for Disease Control and Prevention and the National Cancer Institute, recommended that the U.S. establish a national strategy for cancer control based on the principles of systems engineering to coordinate the priorities and actions of multiple stakeholders and to improve resource integration and promote joint accountability. The report recommended that HHS, in cooperation with a wide range of federal agencies, should lead the U.S. National Cancer Control Plan. So I want to talk a little bit about states because they do play a major role in the United States cancer control efforts. Because CDC recognizes the benefits of a collaborative approach to cancer prevention and control, in 1998, it launched what is now the National Comprehensive Cancer Control Program. The program is founded on the premise that we can do much more together than as individuals, and therefore requires each program participant to convene a statewide coalition of diverse multi-sector stakeholders to assess its burden of cancer and to create and implement a strategic plan that prioritizes approaches to addressing it. NCCP provides the funding, guidance, and technical assistance that state programs use to design and implement impactful, strategic, and sustainable plans to prevent and control cancer. And since the launch of NCCP, CDC has developed performance measures included in state and local cancer plans and identified areas of achievement. Currently, we fund 66 program awardees in all 50 states, the District of Columbia, Puerto Rico, 8 tribes or tribal organizations, and 6 U.S. associated Pacific Island jurisdictions. They implement a coalition-based approach to preventing cancer, promoting early detection of cancer, supporting cancer survivors, and reducing cancer disparities in their communities as outlined in their statewide cancer plans. Those coalition members or partners include state and local government representatives, nonprofit organizations, the American Cancer Society, the Lung Association, the Cancer Survivorship Network, Gilda's Club, etc., just a variety, academia, healthcare organizations, community-based organizations, businesses, and elected or appointed government officials. The comprehensive cancer control plans identify how an organization or coalition addresses the burden of cancer in its geographic area, and the plans are specific to each region and based on data collected about people who are actually living in those regions. They take the strategies that have worked either in that region or in other places and make them part of a blueprint for action. There is much additional work being done within HHS, including our Title X program on population health, which includes a program for breast and cervical cancer screening and prevention. HRSA coordinates the National Center for Health Workforce Analysis and collects workforce data, develops tools for projecting workforce supply and demand, and evaluates workforce policies and programs. The Agency for Healthcare Research and Quality performs and funds research to improve the quality, safety, efficacy, and effectiveness of medical services, and it makes those findings publicly available. Our Indian Health Service ensures that culturally appropriate cancer services and surveillance are available and accessible to American Indian and Alaskan Natives to reduce health disparities and ultimately to reduce the cancer burden. And the EPA, or the Environmental Protection Agency, publishes guidelines for evaluating a chemical's potential carcinogenicity, and it sets the national environmental standards for air quality. So I do want to say we have a lot going on, but it is just thrilling to see the EU embark upon this EU plan. And we have so much in common in this area. First of all, your initiative to vaccinate at least 90% of the EU target population for girls and significantly increase the vaccination of boys is fantastic. This is also a priority for HHS, and every year the United States, 35,000 women and men are estimated to be diagnosed with cancer that is caused by HPV infection. One of our goals in our Healthy People 2020 objective is to increase the proportion of adolescents who receive those recommended doses. We have a national campaign that we've developed at CDC to focus specifically on the gynecological cancers, including cervical cancer. Your additional initiative focused on screening is something that we are also extremely interested in and are working hard to accomplish ourselves. We are very concerned about the impact of COVID to screening in this country and what will happen as we begin to enter, hopefully, a recovery phase. How do we get people back into screening? There are multiple objectives in Healthy People 2030 that focus specifically on things like colorectal screening, using the most recent guidelines, as well as cervical cancer screening and breast cancer screening. We are partnering ourselves to promote colorectal screening right now. We have an educational and research initiatives, including the Screen for Life National Colorectal Cancer Action Campaign, and a variety of scientific studies that are designed to determine the barriers to colorectal screening. Our National Breast and Cervical Cancer Early Detection Program provides quality breast and cervical cancer screening and diagnostic services to low-income, uninsured, and underserved women, and support strategies to increase screening rates in health systems and communities. The CDC is working with public, nonprofit, and private partners to address breast cancer in women younger than 45 years of age, also through a variety of additional activities. And your EU policy objective of improving the quality of life for cancer patients, survivors, as well, is very important to us in the United States as we see this population growing. And how we work with public and nonprofit and private partners to develop and implement ways to support this growing number of cancer survivors is critically important. The CDC is currently funding the National Cancer Survivors Resource Center, which is a collaboration between the American Cancer Society and the George Washington University Cancer Institute. The center develops and distributes a broad range of informational materials, including clinical care and provider education materials. There are so many commonalities that we will hopefully work with you on as you embark upon your plan. We do also admire the fact that you're thinking about reducing the cancer inequities. As you heard earlier, this is of grave concern to us in the United States. So we hope that you will learn from us and we can learn from you along the way. As we also are, your objectives around helping children with cancer initiative will be something we will be looking at closely. Our pediatric cancer rate does have dropped in the United States by nearly 70% over the past 40 years, but it's still a leading cause of death from disease among children from birth to age 14, and about 15,000 children younger than 20 every year are diagnosed with cancer. So with that, there are many, many programs I could talk about, but hopefully this gives you an overview of what we are doing here in the United States. And again, we applaud your efforts as colleagues across the ocean. Thank you.
Thank you so much, Dr. Hacker, for that whirlwind tour. We're now going to turn to the portion of the program in which we have a panel discussion to reflect a little bit on the new plan and also on what we've just heard. So let me quickly introduce our four panelists, starting with Mr. Ryan, who you already have met. We also have joining us Dr. Otis Brawley, Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. Dr. Brawley is a globally recognized expert in cancer prevention and control who currently leads a broad interdisciplinary research effort on cancer health disparities at the Bloomberg School of Public Health and the Hopkins Kimmel Cancer Center, which is striving to close racial, economic, and social disparities in the prevention, detection, and treatment of cancer in the U.S. and worldwide. Next up is Dr. Lisa Carrie, the Richardson and Marilyn Jacobs Pryor Distinguished Professor in Breast Cancer Research and Deputy Director of Clinical Sciences at the Lindbergh Comprehensive Cancer Center at UNC Chapel Hill. Dr. Carrie's research interests focus on breast cancer and efforts to better understand the molecular subtypes of this cancer with the aim of developing better prevention and treatment strategies. She is a worldwide expert in triple-negative breast cancer and led the first trial looking at a new drug regimen in this cancer subtype. Finally, rounding out the panel is Shelley Fold-Nasso, CEO of the National Coalition for Cancer Survivorship. Ms. Nasso joined NCCS in December 2012 and was named CEO in 2013. Previously, she served in leadership roles at Susan G. Komen. So thank you, all of you, for joining us. To get us started, I'm going to turn back to Mr. Ryan for just a few additional reflections, if you would, on why the decision was made now in the EU to put together a comprehensive plan like this for the continent. You want to talk a little bit about the timing?
Yeah. So just to explain to our American colleagues who are online, the European Commission is the body within the European institutions, the European Union institutions, which has the right of initiative. In other words, it's the Commission for which I work, which has the responsibility under the treaty establishing the European Union to make proposals And it's the European Council, the Council of Ministers, which brings together the ministers from the 27 member states and the European Parliament, who then collectively, Parliament and Council, make the decisions on the basis of the proposal made by the Commission. So that's just the political background, if you like. And the Commission is not there eternally. The Commission is replaced when its term is finished. So each Commission has a political composition. The commissioners are nominated by the member states. They're approved by the European Parliament, and then they're in place for a certain period of time. And each new commission which comes into place has its own policy program. So a little bit like President Biden, when he was elected, he had his own policy program. In the European Union, the Commission, when it's coming into its term of office, will also present a number of ideas. And one of the ideas which the Commission had when it came into office was to launch a Europe Beating Cancer plan. It didn't really say very much more at that stage than that they wanted a Europe Beating Cancer plan. And it was really up to the people who work in the Commission, like myself, to try and come up with a credible plan. And that's why we immediately launched a process of consultation where we discussed with the outside world, with oncologists, with cancer patients, with the pharma industry, with the medical devices industry. We discussed what would be the best areas where we could focus on. And we thought that prevention, of course, is an eternal topic in public health. We thought that that would be a good topic to start with. Secondly, the area of early detection and screening. Thirdly, the area of treatments and care, cancer care. And fourthly, everything to do with the patient. And the patient, including the carers, people who care for cancer patients. So actually, this all came at the right time because we had the opportunity then to also link the initiative, the cancer initiative, with the budget, because in the European Union, another strange thing about the European Union is that we have a 7-year budget. So in other words, we can see to the horizon of 7 years how much money we will have to spend between now and the end of the budget period. And this is a great advantage if you think about it, because it means you can do a longer term planning. So the cancer plan, the Europe Beating Cancer Plan, is actually accompanied by a financial perspective. In other words, we've tried to work out what would be the relative investment for each of the actions that we identified. And also on the research side, I didn't speak about research earlier on, but the research program of the European Union also has a substantial initiative on cancer. And this will also be of great interest, I think, to the colleagues on the US side. And just to acknowledge that the US, in fact, inspired the European Union many years ago, because this is our second Europe Beating Cancer Plan. We had a Beating Cancer Plan 30 years ago, which was actually inspired by President Nixon's cancer plan. So going back into history, the origin of the first Beating Cancer Plan 30 years ago in Europe was the Nixon cancer plan. And now I'm very happy to be able to present to you our second Beating Cancer Plan, which also draws inspiration from international models. Thank you.
Thank you for that background, Mr. Ryan. Let's go to the other panelists now, and obviously this is a comprehensive plan with many pillars, any one of which we probably could spend days talking about. But let me start by asking each of the rest of you what specifically jumps out at you from a U.S. perspective in terms of what the leaders of the EU are trying to do here. And Dr. Brawley, let's start with you.
I'm sort of envious that you have a plan, a well thought out plan. In the United States, we've had the National Cancer Act, which is let's do a bunch of things about cancer. But we've never really had a strategic plan that was well thought out. And you're trying to balance things very nicely. In the United States, I personally feel that we overstress screening. Screening is very important, but we overstress screening and treatment, and we don't have enough emphasis on, you call it prevention, I would prefer to call it risk reduction, doing things that end up leading people to have a lower chance of ever developing cancer. We don't have much emphasis on that other than tobacco cessation or tobacco control.
Dr. Carrie, what jumps out at you as you look at this plan?
Yeah, I think Dr. Brawley, hit on, I think, a key element. I mean, this plan starts with, we'll say prevention, because they said prevention if you prefer, risk reduction, which is clearly better than treatment, right? For so many reasons. I'm a practicing medical oncologist, and I can tell you that if you have to have cancer before I can do anything about it. And once you have cancer, I have to treat you, and it's expensive, and it frequently is unsuccessful. And it produces issues in survivorship, even if you're successful in controlling the cancer. So I like that it starts with that. It is hard, right? Risk reduction is multifactorial, including things that are, the own mutational status of your body and things you may not be able to control through lifestyle or even medical interventions. So I think the emphasis on trying to be very, very deliberate and invest in the research around it is very important. I think the other part that I think is hugely relevant, and it is as relevant in the EU as it is in the US, are the issues of disparities in outcome across different subsets within your societies. We have a huge problem with that, which tends to get worse as your strategies and technology get better, because dissemination is not equal, and that's where access and issues of that start to become hugely important. So unless you invest in that from the very beginning, you will actually see a widening of outcomes amongst your underserved groups. So I think that deliberateness is also very well appreciated and appropriate.
Ms. Nasso, what strikes you in looking at this report?
So I appreciate the comments of Dr. Brawley and Dr. Carrie and agree about those as it relates to risk reduction and reducing inequalities. But one of the things that really struck me was the fourth pillar about the quality of life, improving the quality of life for cancer patients and cancer survivors. That's something that we focus on quite a bit at the National Coalition for Cancer Survivorship. And I think, I see that cancer patients in the EU are facing the same challenges that cancer patients in the United States face in terms of challenges with coordinating their care, sharing data about their treatment and their health needs going forward, employment issues. I really appreciate the emphasis on caregivers and supporting caregivers, because they're integral to the experience of the cancer patient. And really, there's a huge burden on caregivers who sometimes have to stop working in order to help take care of a cancer patient. So I think that, I was very interested in some of the specific initiatives around quality of life, including, better life for cancer patients initiative, and then the Cancer Survivor Smart Card to really help cancer patients carry that information to cancer patients often have to see multiple different specialists to help take care of some of the late and long-term effects of their cancer treatment. And coordinating that care is challenging. And I think it's a really innovative idea in the EU Beating Cancer plan to have this Cancer Survivor Smart Card to really help with that exchange of data and monitoring of the health conditions that cancer patients face after their treatment.
Thank you. I'm seeing a few questions starting to come in from the audience. I want to encourage all of you to jump in there and send us your questions so we can get to them as well. Let me jump in on something that Dr. Brawley and Dr. Carrie mentioned about prevention, because I've been covering health policy in this country for about a dozen years. That's not all the way back to the Nixon administration, obviously, but long enough to have picked up on a few patterns, one of which unquestionably is the number of times that I've heard clinicians talk about their desire to have a greater focus on prevention. This isn't an old idea. We've had many struggles in this country trying to shift our healthcare system in that direction. Some, such as tobacco cessation, as you mentioned, showing some success, but many others that frankly have not been terribly inspiring. What can we take from that experience that may inform what the EU is trying to do, and presumably what we should be trying to do in this country too? Who wants to take that first?
Well, I'll start out by noting that when we talk about risk reduction or prevention, we're talking about somewhere between 40 and 60% of all cancers are due to either smoking or a combination of obesity, too many calories, and lack of exercise. We'll call that energy balance. So energy balance and tobacco use is 40 to 60% of all cancers. If we got rid of those problems, 40 to 60% of all cancers would go away. It's also important to realize, and it's in the European Cancer Plan, that will decrease diabetes, that will decrease cardiovascular disease, that will decrease a lot of the chronic diseases as well. And so we need to work on how to teach people to live a healthy life. Healthful promotion of healthy habits is a hard thing to do in the United States healthcare system because it's very difficult to find a way to fund it in order to promote it. In the European system, I think it's a little bit easier.
Dr. Carrie?
Add to that, the truth is that these are really thorny problems, right? No one, societally or individually has decided that they would like to be obese. Even tobacco cessation, which is touted as a great, success story. I come from a state where 17% of our citizens still smoke. And an ever increasing proportion of our citizens are obese, which is not generally entirely volitional. It is also a product of societies as they become more wealthy, tend to have poorer food choices. To be honest, from a health standpoint, there's more accessibility of food, and behaviors are far less active. The things that you do just to be, functioning in society and in your day-to-day life tend to be sitting on Zoom calls for hours and hours at a time. But the truth is our lifestyles are much less conducive to being healthy than they were, decades ago. So this is a really big, thorny problem. It isn't simply a question of teaching people, what the difference between a Big Mac and an asparagus spear. There's also a huge societal, industrial emphasis on foods that aren't necessarily healthy for you. So I agree 100% with what Otis just said, but it's almost beyond a cancer control and risk reduction issue or diabetes or heart disease. It really has to do with the way modern societies are constructed, which of course makes it much more expensive and harder to fix. And there are stakeholders who are not invested in it.
Ms. Nasso, is this idea of prevention and healthy lifestyle in the survivorship context something that you have thought about, and what have you seen from a policy perspective could inform what the EU is trying to do?
This is definitely an issue in survivorship because we do a state of cancer survivorship survey of cancer patients across the country. And in our survey last year, one of the things that cancer survivors said that they wanted more information about was really how to maintain a healthy lifestyle, how to maintain a healthy weight, nutrition. So once, this is more in the risk reduction for secondary cancers. Once somebody's been through a cancer diagnosis and cancer experience, they want to do whatever they can to try to help reduce the chance of having a recurrence or a second cancer, and often are left without the information that they need to really help manage their health. I think also I just wanted to point out, and Dr. Brawley knows this because I think he's heard from advocates at one of our events, that a lot of cancer patients and advocates really prefer the term risk reduction. Dr. Carrie mentioned that term because, I think the points that Dr. Carrie made about what a thorny problem this is, in terms of the way our societies are constructed, and you can do everything right and maintain a healthy weight, exercise, not smoke, all of these things, and still end up with cancer. So it's not prevention as much as it is reducing risk. And I think that's really important to cancer patients because they feel like then the onus is on them. Like, what did I do wrong that I ended up with cancer? And they didn't, in many cases. And even I think there's also, of course, a stigma for cancers that are tobacco related, where, choices may have impacted the cancer, and so lung cancer patients often feel a stigma. So I think, from a policy point of view, there are obviously, it is a huge problem because it is a way, as Dr. Carrie said, the way our societies are constructed, that we don't get as much exercise in our daily lives as we need to. And there are, forces that work against, making those healthy choices in terms of even the availability of healthy foods in certain areas of, food deserts in cities where you can't get the healthiest foods, and unhealthy foods are cheaper than healthy foods. So I think that, it's a big problem that we have to address. And I think it's good to see the EU addressing it in a holistic way, and I hope that we can do that as well in this country.
Mr. Ryan, when you were thinking about harm reduction or risk reduction strategies for the EU, what kind of policy levers were you looking at that the U.S. had experimented with, that member states had worked with in the past, and how did you think sort of comparatively about some of those different policy options to address harm reduction?
Well, first of all, I'm very grateful for this exchange of views because it brings a lot of arguments to the table. I would say that the advantage of the Europe Beating Cancer Plan is that we try and pull as many levers as possible, and not just the public health levers, but also other policy levers across government. And that's why I emphasize the point that this is a health in all policies approach with a target of cancer. Taking up the point you made about these other policy levers, the European Union has a very, very strong agricultural policy. And one of the things we did, if you read through the Europe Beating Cancer Plan, is to try and identify where in the agricultural policy, for example, there were elements which could be mobilized to reduce cancer risk. Here we're talking about things like promoting healthier foods, promoting healthier foodstuffs, or even the growing of healthier foodstuffs. We have subsidies in Europe, as you have in the United States, in order to promote and protect certain types of farming. And therefore, by channeling investment and channeling government funding into the production of food which is healthier, by definition, you will have downstream effects on people's health. This is not sufficient in itself because, of course, you have the commercial determinants of health, which I think Dr. Carrie was hinting at. You have substantial industries who have a stake in selling certain types of food, and therefore involving the industry in your ambition to reduce cancer is also important, whether that's in terms of marketing and avoiding the marketing of foods high in salt, sugar, trans fatty acids to children and young people. This is an important component, and we have the legislative tools there which we can use to avoid that. For example, in the legislation which we have in the European Union on media, including television and social media, we have possibility to avoid marketing of unhealthy foods to vulnerable populations, particularly young people. Another example is the area of taxation, where we hope to be able to mobilize taxation tools, particularly in the areas of tobacco and alcohol, as we're doing at the moment, and we hope to do in a more reinforced way. And I would mention as well the policy of transport, which people often forget. So public transport, walking, cycling, all of these softer ways of transport, which can also improve people's health, if done at a community level and if done over time. I'd just like to close by saying that we have a major stimulus in Europe to do something better as regards cancer, because cancer is the second biggest killer in Europe. It's the second biggest disease with cardiovascular disease. And therefore, with an aging population, of course, you have an increase of the burden of this disease coming naturally on our health systems. And therefore, it's important that we do everything we can to increase the prevention side, or the risk reduction side, if you like to call it that. The figures which we have from the OECD, the Organization for Economic Cooperation and Development, say that 3% of our health budgets are spent on prevention, 97% spent on care. Now, even if you were to increase slightly the amount you spend on promoting risk reduction, this would already be an improvement. Thank you.
Thank you. Thank you for that interesting discussion. I want to get to some audience questions, but if we can, in relatively brief fashion, address what a number of you talked about in terms of health disparities. There's, I think it's fair to say, some expectation in this country that the current political discussion about disparities can help change thinking within healthcare about outcomes in cancer. Maybe for the U.S. participants first, can you talk a little bit about sort of where you see the most promising kinds of initiatives to tackle either prevention or harm reduction, screening, or treatment? And then, Mr. Ryan, maybe we can go to you and I'll put the same question to you about what you see on this side of the Atlantic as being hopeful and what you're hoping to do there. So, lightning round here on a huge topic, but let's start with you, Dr. Brawley, again.
Yeah, Ms. Nasso brings up a very important point. We don't want to blame the cancer patient. What we need to be thinking about is changing community, changing culture. We have done some good things in terms of changing culture in the United States in regard to getting people to not want to smoke. At the same time, unfortunately, that change in culture caused many people to start blaming lung cancer patients, for example, for giving themselves the disease. I would rather focus on educating young people. Sometimes I think fixing third grade and getting folks in grade school to appreciate the importance of exercise, also get their parents to appreciate the importance of a balanced meal and keeping smoke away from them. Those are the things in risk reduction I would talk about. And then, of course, we do have a huge problem in terms of a large number of people not having adequate access to care, be it prevention, screening, diagnosis, or treatment.
Dr. Brawley, do you want to say anything about sort of what you see in terms of disparities and policy here to address those?
The way I would try to fix it, or the policies that I would try to implement, would be primarily educational policies. Do it through the schools primarily, as well as I wish everyone could have a health counselor. That is a coach that go to this health coach to learn the things that you ought to be doing to try to live as best a healthy life as possible. Realizing, again, there are some people who do everything that they should do and do it exactly right and still end up getting this disease.
Dr. Carrie?
Yeah, I think, as always, Dr. Brawley did a fantastic job framing it. And I'm going to also speak to Ms. Nasso's comment, which I think cannot be understated. I can't tell you how often a patient comes to me and says, what did I do wrong? I mean, they really blame themselves and then sometimes try and do slightly crazy things to control their cancer, thinking that this is their responsibility. And I don't think we want to establish a culture that sets that expectation, because, to be honest, it's not realistic and it's not true. That said, if we want to address disparities, and speaking specifically to that question, I think there's two things that are key. The first is what Dr. Brawley mentioned, which is education and changing the culture and the way people perceive, the way they should live their lives. And I'll use as an example, so I have, now adult to near adult children, and in their group of friends, they don't smoke very much, which is a huge blessing. It seems sort of an odd thing for them to do. They also don't drink alcohol and drive, right? I mean, these are simply things that were embedded into their culture through education, that it became natural to them. So I think doing whatever we can to create, it's hard to change people once they've decided to be a certain way and they become hardwired, but you sure as heck can do it with kids if you make it rational and you're consistent in the messaging. I think the second thing I would do that to reduce disparities gets back to the original problem, which is, as you have tools in the toolbox to do things, you also have to consider that if it's very expensive to do them, then people aren't going to be able to, even if they are motivated to do so. And so the kind of things that Director Ryan was commenting on, strategies to level the playing field to make it feasible for people to act in a healthy manner, are crucial.
Ms. Nassau, do you want to jump in?
Sure. I think that, one of the things that we've worked on quite a bit with other advocacy organizations is just access to care. So I think Dr. Brawley and Dr. Carrie talked about some things we need to do to help with the risk reduction, and that will also help with disparities. But also access to care is so important, and we've advocated on behalf of the Affordable Care Act because it's really expanded access to care for cancer survivors who before the Affordable Care Act could often not get insurance because of their pre-existing condition. Also expanding access to Medicaid has been shown to reduce some of the disparities in care. So that's one step. Once you've been diagnosed with cancer or facing cancer, being able to access the care you need is critically important. I think education is really important, but I think when you, and especially when we're talking about the things that are more in the risk reduction and healthy lifestyles. But once you're faced with a cancer diagnosis, then everything is different because you're faced with making all these difficult decisions about your treatment and managing and coordinating your care yourself. In our survey that I mentioned before, by almost a 3-to-1 margin, the mindset of cancer patients in terms of decision making was to do what their doctor knows best, do what their doctor tells them. So all the education and kind of empowering patients is important for some patients, but there are also many patients who are just so shell-shocked by their diagnosis that they're just going to say, you tell me what to do. So I think we have to make sure then that the system works for everyone, not just the patients who can be empowered and I think health literacy is important, but again, it's not going to solve all problems, because once you're faced with that diagnosis, sometimes you just want someone to help you and guide you to do what you need to do. And so we have to make sure that patients aren't getting lost in the cracks, and that the care that they receive is adequate no matter where they go, because I think there are some of the disparities in care may have to do with where they are being treated and what kind of services are being offered to them. So to me, those are some of the things we need to think about when we're talking about reducing disparities.
Mr. Ryan, there are so many issues with access to care in this country that I presume are probably more of a cautionary tale than perhaps a model for policymakers in the EU. But as you thought about disparities and again tackling that, what did you look at over here as helpful, and I guess maybe what did you try to avoid? I can't, Mr. Ryan, I don't think we can hear you at the moment. Are you muted?
Can you hear me now?
Still can't. Yes, now we can hear you.
Okay, sorry about that. So I wanted to speak on this point of access to care because clearly the situation is different, but it doesn't mean that everything is good and everything is bad on one side and the other. So we have what we call the European Charter of Fundamental Rights, which gives a certain number of principles at the European Union level to citizens, one of which is the access to quality healthcare. And generally speaking, in the member states, the healthcare systems are paid for through the government budgets and through the taxation system. And then if people want a specific level of additional care, they can subscribe private insurance. Now, there are different tweaks in that general description, but generally speaking, what I'm saying is that there is a public health system which provides prevention to care, if you see what I mean. It provides the whole spectrum of health care. But that leads to the problem that, of course, depending on the budget that's available to a particular member state, the quality of care can either be better or worse. And this leads to the inequalities which I was talking about. They're not all due to the social status or the educational status of the patients. They're also due to the amount of money that's available to be invested in the system itself. So even if the system was 100% fair, you would still end up with inequalities because the amount of money that's spent on patients differs. And therefore, one of the ambitions that we have is to try and make sure that the access to diagnosis, the access to treatment is done in the most efficient and in the most effective way possible. There's a whole chapter of the cancer plan dealing with ensuring access to essential medicines and innovation. You know that very often there's this problem of new treatments which come offline and which come out of the clinical trials, and then the issue is how do you pay for them? So, and of course, this is done very often in a way that's not particularly fair. So the Commission is proposing to work with the member states on what we call health technology assessment procedures, where in addition to looking at the clinical trials outcomes, we would also then consider what is the value added of a particular product to be included in a menu of products which will be made available. So the Cancer Diagnostics and Treatment for All initiative is really focusing on a number of elements to try and improve the access and quality of care for cancer patients. Several people now in the roundtable so far have been discussing the issue of stigma, and I recognize that this is a topic by giving a false impression that you can prevent cancer, and then of course if you get a cancer there is this feeling of guilt. So this is something, of course, we have to work with the medical profession, with our stakeholder groups, in order to make sure we don't give that impression. But I still think that when you're faced with 97% of your budget going on cancer care, it is important that we try and refocus attention on what we can do better through the different policy levers to reduce the burden of cancer, starting on the supply side, if you like, or at the beginning of the pipeline rather than at the end of the pipeline. So this is why we try and have a plan which is balanced, which looks at all the different aspects and which tries to pull as many policy levers as we can. Thank you.
Thank you, Mr. Ryan. We're running toward the end here, but I would be remiss in my moderator duties if I didn't alert our audience to a poll that that your hosts are putting together here. So we're going to ask you to answer a brief poll on your screen as the EU values your feedback and can keep providing meaningful events for you. So look for 4 questions that should appear on your screen. Question 1, prior to this event, what was your perception of the EU on the topics discussed? Question 2, after this event, what is your perception of the EU on this topic? Question 3, do you agree that you benefited from the webinar? And question 4, did the organization benefit from attending the webinar? So look for those, and please, in the last couple of minutes, see if you can just quickly tick through those. I know that would help our hosts immensely. And while you're doing that, I am going to hopefully get a live question to our panel from Kathleen Linder from the University of North Carolina. Can we hear from Miss Lindler? Okay. I think we can hear you. Wait. Did anybody hear the question? No. Okay. Well, let me. Sorry about that. We have about 2 minutes left here, so let me see. I'm so sorry, Ms. Linda, that we couldn't do that. Let me see if I can grab one question from our queue here, and see if we can get to those questions. So Ms. Linda was asking about joint EU and US projects that may be possible from a research perspective, and that I presume may be more possible as a result of this cancer plan and what it may manifest. So I don't know, maybe that's a question for you, Mr. Ryan. What does this open up any new possibilities for transatlantic research, either policy or basic science?
Yes, it opens a lot of possibilities. I'd have to put you in touch with my colleagues who are responsible for the research program in order to work out the details. But research, by definition, is something that's international and open. And certainly we would be very happy to explore what the possibilities are for working together on particular topics. I'd just like to mention here that we have been working together for a number of years with the United States government in respect of antimicrobial resistance. We have a transatlantic partnership on antimicrobial resistance, which is still alive and kicking as we enter the Biden period. And the whole purpose of that is really to look at common objectives on antimicrobial resistance, which is the next COVID, by the way. And I think it's really significant that the United States and Europe are working on this together with Canada, Norway, and a couple of other participants. And we would be very happy also to continue this dialogue on cancer in the same way.
Thank you, Mr. Ryan. Well, I think that pretty much brings us to the end of this panel. Thank you to all the panelists, and thank you to the EU for this marvelous document, and best of luck. Thank you all for joining us. Have a nice day.